Have you heard of something called Alleviate for doing your own self-Graston with the patients themselves? Welcome to Podiatry Practice Mastery. My name is Pelto. I want to share a new type of a device that we have. I don't use a lot of it. I kind of think I probably should use more of it, but I don't. So this device is called Alleviate, Alleviate. You can look it up. It is almost like a self-Grastoning tool for the bottom of the heel. And I had a patient today. She was status post 6 shockwaves. She came back 6 weeks later. She's about 50 to 60% better. On her ultrasound, she had a lot of thickness and a lot of effusion. And so I could tell that the fascia wasn't completely better. And I usually at this point, I do 6 weeks the first follow-up, and then I do 12 weeks at the next one. And so I give patients, they can either go to physical therapy at this time, or this time I thought, well, heck, we should try this Alleviate thing. So the Alleviate, I'm going to try it out. They have a lot of good reviews, and I think it's kind of an option for patients that have painful plantar fasciitis. That's what it's marketed to. It was invented by a physical therapist. It is a device that has almost like tentacle legs that open up, like an octopus, and then it has kind of a smaller lump and a bigger lump. And these lumps you put on almost like not a gel, but a grease or some type of a oil that can help it to massage on there. And the patients do 2 to 3 minutes of deep tissue massage in that area to help probably the similar things to what like a Graston technique would be doing, breaking down the hard tissue and stimulating blood flow to the area. It's a pretty reasonable tool. It's about $75 for the tool. They have a kit that you can do the tool, massage. I think it has like an ankle brace type of thing and like a compression sock. Why don't I use it a ton? I don't use it a ton, frankly, because I think I get good enough results with just the shockwave. And then patients, they may or may not go to PT. So it might be an option to avoid, because I don't have patients go to PT most of the time, so I have them, if they want to do something at home, they can do this. It's just another add-on. It seems like a good product. I'd like to know if anyone else is using it. It's called Alleviate. Okay. Another question I actually had for people. Does anyone do their own Charcot AFOs? I had a patient today. This is a 53-year-old man. He looked like he had a navicular fracture, but I was very susceptible for Charcot. And he had a back injury where he is pretty much mostly neuropathic on the right side, and he developed a Charcot foot. So he's been in a boot, cam boot, and then I'm going to make him a crow boot. But I was thinking, man, if I could start doing these crow boots, I know I can with my scanner. I just get a little bit worried if I have to add more padding and things like that. So I'd like to know if anyone else does their own crow boots. Shoot me an email down at podiatrypracticemastery.com. So this guy, he came back after the MRI, did x-rays. It's within the global, so it was kind of a low-value patient, but if I could have done the crow boot, it would have been better, but I sent him out to Hanger. Next patient was a left heel pain, 45-year-old female. She's had it for 2 years. We did an x-ray, did an ultrasound. She did not have any equinus, but she had pain down there, so I set up shockwave times 6, so I'm going to see her back for that. Next patient was a 59-year-old man for right medial heel. He did shockwave there, and this was number 1 out of 3. And the reason it was 1 out of 3 is because previously he had 10 sessions of softwave by another chiropractor, or it wasn't a chiropractor, it was their office. And he wanted to do ours because he got some improvement with it. I don't know why he didn't go back to them, but he wanted to see us. Next was a 63-year-old female for left her second post-op, suture removal for neuroma. She is doing fine. But I did send a message. I was on vacation when this first post-op was done, and it was another, we have a younger doctor here that's just starting out, and he was kind of complaining a little bit when I traveled about doing my shock waves, and maybe they had prepaid for them, so we didn't get paid. Or didn't count towards his numbers. And my thoughts to that is I think when you're not that busy, like any patient fine, right? When you're still kind of starting out, I think it's good to get the practice with the patients, the face time, they get to know you. But one thing I told him, I'm like, all post-ops would get a cam boot, and they came in a surgical shoe. So pretty much all of my post-ops, I don't give them the cam boot at the hospital because I want to bill for it. So I actually do it at my first post-op. And maybe he didn't know that. Maybe he didn't think you were supposed to do that for a neuroma. But it was something that I think there was kind of profit left on the table there. But I think most patients are better in a cam boot. So those simple things, I think it could have helped his billing if he had done that, but he didn't. Next was that 55-year-old female that I did Alleviate for, that I talked about in the beginning. Next was a 63-year-old female for a right ingrown. So she had a onycholytic nail about on the right hallux, about half the nail, and it was digging into the skin. So she had a pyogenic granuloma that was producing on the dorsal nail bed about halfway down. I did a partial nail avulsion back about maybe 3 or 4 millimeters from the area of the granuloma, and I debrided that down. So I billed for a partial nail avulsion. On the other side, she also had a previous OnyFix application to try to get her nail to get a little bit less thick. So I ground that down, and I put a second OnyFix for that. So OnyFix, I don't do a lot. I've been doing some of these a few days. So it's like a speed bump that you put on that helps kind of guide and direct the nail. It's typically used for ingrown toenails, but I'm also trying to do it for onycholytic nails and some of these thick wavy nails as another option. Next was a 37-year-old female that had left MRI of her talus, and it showed bone marrow edema around the talus and the subtalar joint region. I gave her 3 options for this. She's had pain for quite a while. She's quite young. She's a teacher. I talked about waiting, giving it more time. I talked about possibly doing an arthroscopic evaluation of it to see if there's like a talar dome lesion, because that's where the bone marrow edema is. And I talked about doing shockwave. She opted, she's going to teach her, so she's going to go back and do the teaching, and maybe during one of her holiday breaks, she's going to do the sessions of the shockwave. Now, this is the downside from this. These ones that I bill initially, when I saw her, I billed as a fracture code. And so this day, all this conversation and things like that, there was no office visit because it was still within the global period of the fracture code. So I think you do well on some of the fracture codes, and you don't do as well on some of the other ones. Same thing with that other Charcot, that was a fracture code as well. Next was a 14-year-old male. He had a little Down syndrome, so he had some hypermobility, bilateral flat feet. I did x-rays, talked to him about doing orthotics. They had Mass Health, which is a Medicaid plan, so they're going to pay 20% of their visit, so they have like an individual plan and then the Mass Health. And so for them, I gave them a prescription to go to Hanger for the orthotics. I do think ours are better, so if they say Hanger doesn't cover them, I recommended them coming back to me. Next was a 44-year-old female for a Cariflex that fell off after 2 months. So I usually guarantee my OnyFixes and my Cariflexes for 3 months. And if it falls off early, I don't charge them for the procedure. I just charge them for the office visit. So it was a level 3 office visit, but like kind of a low-value patient because of that. Next was a 25-year-old man with a left hallux fracture. He had a little distal avulsion. He got a fracture code. And I also did a nail avulsion on him. So I did a nail avulsion, fracture code, and I'm going to see him back in 4 weeks in a cam boot. Next was a 65-year-old female. That was the morning. This is the afternoon. 65-year-old for a left Achilles tendon pain. Patient is going to do foam rolling, meloxicam, and they're going on vacation, so I give them a Medrol dose pack in addition to the meloxicam just for some breakthrough pain if they need it, and I did an x-ray. I'm going to see them back when they get back, but they're going on vacation, so they need something to calm it down. Next was a 45-year-old man with a second toe fracture follow-up, still within the global, so I just got the x-ray for this one, and he's going to come back in 4 weeks. Or he's not going to come back at all. He's doing fine. So I think some of these, even these fracture follow-ups, I'm going to start putting in my, like double booking in my 10-minute slots, because they're simpler procedures, and they're kind of low-value patients in terms of it doesn't really take that much time, and it doesn't take that much thinking, so I think it would be a quicker slot. Next was the left hallux matrixectomy for an 18-year-old female. Next was a 49-year-old female with, she had a previous cortisone injection in the right, third, and fourth interspaces for a neuroma, and she didn't want surgery. She didn't want cortisone again. She's already tried anatomic shoes, and so we talked to her about doing shockwave. So she did shockwave on those interspaces. So when you do shockwave, I did focused only, and I did 0.05. So I do very, very low shockwave. They can still feel that. You have to respect the nerve tissue. So nerve tissue is not like fascia tissue or tendon. A lot more sensitive. So I did 0.05, very low focus, 2,000 pulses. This is number 1 of 6 for her. So she wants to try to do this treatment, non-invasive, or no cortisone and no surgery. Next was a 24-year-old man with a right ingrown toenail, so I did IND. Next was a 72-year-old female. Did a nail sample. The nail was partially detached and had possible fungus. I'm going to see them back in 3 weeks because I wasn't too sure because of the detachment or the onycholysis. I'm not sure if it was like a bacterial infection underneath it because it was detached and water got underneath there, or if it was real fungus. That's why I didn't actually start them on the medication. I'm going to see them back in 3 weeks. Next was a 55-year-old man. This is a guy that deals with some chronic itching /tinnitus / eczema. So he's not sure what he has. He had some like scratches on his lower ankles. He's a self-pay patient, and he tried after a couple years to send a refill request to the pharmacy. So I get this sometimes. If I haven't seen patients in a year and they ask for a refill request, I tend to have them come in because I want to reassess the situation. But for this guy, I did prescribe an antifungal and a clobetasol to help with that itching for him. Next was a 47-year-old female. I did an ultrasound on her. She has plantar fasciitis and Achilles tendinitis, but she has a normal ultrasound. And I think the reason for this is she has very, very bad equinus. She's very, very tight. That's why she's getting the heel and the plantar foot pain. I referred her for physical therapy, and she already has the night splint, foam rolling, morning stretch, all that other stuff. If that doesn't get better, then I did suggest that she would come back for shockwave. I think shockwave would benefit, but I think the bigger portion is the tightness that she has. And kind of the most interesting patient of the day is this 33-year-old female. So she had a right knee arthroscopy for an ACL repair and a meniscus. And she came in, she's about 2 months, and she was in crutches, not for her knee, but for her foot. Her foot was hurting her. She had foot pain. She had kind of nerve pain. She had pain kind of near the second and third met head digit region. And she had a lot of tightness. So I did a few things. She had tenderness in her calf, so I'm going to rule out DVT. I did like a massage ball on her calf. And then when I did it on the calf, some of the foot pain went away. So I think some of it could be tightness from the knee or like the immobilization or not being as active. So she's going to do some foam rolling on that area to kind of loosen up that area. And then it also could be because I think she had a thigh tourniquet. And so some of it could be like a neuropraxia, like a nerve pain. So she's already on gabapentin 100 milligrams. So I suggested she up that a little bit to 300 to see if that would help it. So it could just be nerve-related issues, but I don't know why it would hurt only at the like a second and third MPJ region in her foot. There was no other soft tissue things. I also considered it could be like regional pain syndrome or something like that. So I suggested she up her vitamin C and things like that. So I don't know if anyone is great at dealing with chronic regional pain syndrome. I am not, but that's how I dealt with this patient. So I'm going to see her back in 2 weeks because I'm concerned with her that she's going to get better. So that's the day. Once again, if you guys found this beneficial, shoot me an email, let me know. I am putting together a 6-month challenge for anyone interested. You can go to podiatrypracticemastery.com. We're going to meet once a month live via Zoom, and then we're going to have like this in-between stuff via WhatsApp. So I think it would benefit anyone that is under $200 a patient and anyone that's under $1 million in personal production. I think it would benefit you. It's the first time we are doing this. I'm excited for this first group of people. We're going to be starting probably at the end of this month. That's end of August. Okay. Once again, look forward to that. If you had any information or you're interested, shoot me an email down at podiatrypracticemastery.com. Helping you. Maybe this is enough, but some people want a little bit more collaboration personally. Okay. Have a great day. See you tomorrow.